Welcome, everybody. Rush University Medical Center Division of Nephrology Renal Biopsy Conference for May 24th, 2022. Today's CME activity code is 485638. If you have any trouble obtaining CME credit, just send one of us a note and we'll make sure you get signed up for it. It's pretty seamless and a advantage we feel of this course. We have a great case today. It's Dr. Whittier's and Dr. Schlotman's. Dr. Schlotman will be, Kelly, our first-year fellow, will be reading the case. These are being recorded and it'll be put up on our YouTube channel shortly after. The patients have been de-identified and all information, gender, ethnicity, dates, exact laboratory values have been changed to disguise the identity of the patient and to protect patient confidentiality. We have nothing to disclose. If anybody's not on our mailing list, by all means, find us, throw us an email. We'll add you to the mailing list, add your friends, all your fellows, etc. I want to say something today, a shout out to all of our past fellows. As I'm looking down the list here, how many have joined us? And we're so thrilled to see you come and take time off from your private practice. We miss you, and hopefully you're here because you miss us, and hopefully you're learning something. So the list is really quite impressive how many people join us. Not every week, but a lot of people come back, and it's really great to see you. So
feel free to share your video and give a little wave. It'd be nice to see the friendly faces that we know.
Yeah, exactly. With that, let's start with the protocol. Kelly, you want to read it?
Sure. Can you hear me?
Yes.
Okay, perfect. Okay. So our patient today is a 61-year-old female with past medical history of recently diagnosed amyloidoma on her left chest wall, who presented for evaluation of worsening AKI on outpatient labs with a creatinine that was measured at 1.89 milligrams per deciliter. Her baseline creatinine is around 0.82 milligrams per deciliter. She was initially noted to have worsening kidney function about a month prior to her current presentation, when her creatinine was measured to be 1.38 milligrams per deciliter. At that time, she was given IV fluids, but her renal function did not improve. A couple of weeks prior to her initial creatinine elevation, she was incidentally found to have a left ninth rib mass during a screening coronary calcium scan. Biopsy of this mass showed amyloidoma with some interstitial small plasma cells. Plasma cells were kappa light chain restricted and demonstrated aberrant expression of cyclin D1. Her kappa light chains were elevated at 199 milligrams per deciliter, while lambda light chains were normal at 9.4 milligrams per deciliter, giving a kappa to lambda ratio of 21.26. Serum and urine immunofixation were negative for monoclonal proteins. Further workup with bone marrow biopsy was subsequently performed and showed 5% plasma cells that were cyclin D1 positive and kappa light chain restricted, as well as 5% mature B cells, which also showed kappa light chain predominance on flow cytometry. Congo red stain was negative. Her past medical history includes hyperlipidemia. She actually underwent the coronary calcium scan for risk stratification because she didn't want to be on a statin. And that's when the left ninth rib mass was found. She doesn't have any surgical history. She does not drink alcohol, use drugs, or smoke tobacco. Her family history is negative for any history of kidney disease. Her paternal grandfather did have colon cancer. Her sister had thyroid cancer, and father has heart disease. Her allergies include amoxicillin and chlorhexidine. She isn't on any medications and doesn't use any over-the-counter meds, including NSAIDs and herbal supplements. Her physical exam was pretty normal overall. Vitals were significant for a little bit of an elevation in her blood pressure to 138/71. Heart rate was 76. Her BMI was 20. And I guess of note, she didn't really have the wall mass or the ninth rib mass that she had wasn't readily visible or palpable on exam. Labs were as follows: CMP, sodium was 141, potassium 4.5, chloride 106, bicarb 23, BUN 44, creatinine 1.89, glucose was 97. Total protein 7, albumin 3.7, calcium 9.9, total bili 0.3, alk phos 35, AST 60, ALT 104, hemoglobin A1C 5.1. CBC showed a white count of 9.09 with a normal differential, hemoglobin of 12.4 with an MCV of 90.8, platelets 225. She had a negative hepatitis panel and HIV. Also, ANA, MPO, and PR3 were negative. She had normal complements. C3 was 110 and C4 22. Her serum and urine immunofixations were negative for monoclonal proteins. Serum free light chains, kappa was 199 milligrams per deciliter, lambda was 9.4 milligrams per deciliter. As said above, her ratio was 21.2. Her UA specific gravity was 1.014, pH was 5. Her UA was negative for protein, glucose, and ketones. She didn't have any white cells, no red blood cells. Her urine urine albumin to creatinine ratio was undetectable, and her UPC was also undetectable. Renal ultrasound didn't show any evidence of hydronephrosis or increased echogenicity. Both of her kidneys were 9.7 centimeters. Her echo was completely normal. A percutaneous renal biopsy was performed.
Great. Any questions for Kelly before we discuss it? We are going to have a poll, but are there any questions for Kelly or Dr. Whittier? Okay, let's go directly to our poll. So today's poll is, what do you think the kidney biopsy will show? So anybody that's not a co-host can vote. So we have about 40 people, 35 people or whatever that should be able to vote here.
And the co-host can put in your in the chat if you want to mention any diagnosis. Those who are not going to discuss the case, at least. Come on, a few more. There you go. Pretty good. All right, we'll end there.
So sometimes we ask this after we discuss it. Sometimes we ask this before we discuss it. I thought it'd be fun to discuss to get it before we discuss it. Sometimes the discussions are so good it sways everybody's vote. So this time I wanted to pick what they thought before it was even discussed. What we have here is about half the people say this is CAS nephropathy. 22% said ATN, 20% said amyloid, and 11% said acute interstitial nephritis. So a nice breakdown. And as I put in the tweet, in reminding that this case was coming up, this is one of those situations where it really plays a role in doing a biopsy. So I'm going to start with discussing. I want to ask Dr. Gashti to open up the discussion. Casey, what do you think's going on?
Yeah, thanks. I'm glad we had the quiz before my differential because I got some ideas. To be honest, I've never heard of amyloidoma. I've heard of plasmacytomas, but it sounds like when they biopsied this mass, there were plasma cells in it. So I don't really know what the difference is between amyloidoma and a plasmacytoma. But regardless, this woman comes in with what seems to be AKI with no serologic findings from an autoimmune standpoint, and urine is pretty much bland. There is absolutely no protein by both dipstick as well as quantification. So right off the bat, it seems to me that whatever the process is that's causing the creatinine elevation is most likely tubular in process or tubular interstitial in process, and much less likely to be a glomerular process, given the fact that there's no proteinuria or hematuria. So just narrowing it down to that, we did have the four diagnoses of CAS, ATN, amyloid, and AIN. I kind of want to throw the ATN out, not out, but just lower that on my list of differential, because I mean, this lady doesn't sound very sick. She's not in the hospital. You know, why would she just all of a sudden get ATN? And if there is tubular injury, it probably has something to do with the light chains, with the kappa light chain, and whether there's a deposition in the proximal tubule causing some kind of a, you know, either crystal, you know, not globulinemia, but crystal deposition, or kind of a light chain deposition type disease, or proximal tubulopathy, or some kind of a light chain related tubular disease. That's one. As most people said, I think Cas nephropathy is probably high on my differential, just because of the level of kappa light chain. And interestingly, you're not finding a whole lot of that in the urine. So that makes it, you know, unless they're all sort of captured in tubule, and we're just not detecting it in the urine. AIN, the one thing that makes me think AIN, besides the fact that I like the diagnosis of AIN in most cases, is the fact that the bone marrow biopsy also had some, I think I'm looking for there were a bunch of plasma cells. And so, you know, we've seen cases of AIN present with the bland urinalysis. We've seen packed lymphocytes or plasma cells in the kidney, and there's nothing that's spilling into the urine. So that's always on the differential. And then amyloid.
Casey, are you saying AIN like general AIN? Are you saying that
No,
this is a plasma cell infiltration?
Plasma
in the
cell
kidney?
infiltration. It would, you know, if there is a interstitial nephritis, it would be a plasmacytic dominance. And then finally amyloid, which, you know, that's pretty much what she has on the other on her rib. So could she have amyloidosis? And it wouldn't be glomerular, because we really don't see much proteinuria here. So it would have to be either tubular interstitial or vascular amyloid, and maybe tubular interstitial without much glomerular involvement. So my order would probably go something like Cas nephropathy number 1. I would say plasma cell rich interstitial infiltrate or interstitial nephritis would be number 2. And then non-glomerular or tubular interstitial amyloid would be number 3. Those would be the lesions that would connect the AKI to her rib lesion. Other than that, she's really, you know, not taking any medication. So I'm not really suspicious of some kind of a drug-induced issue. I'm assuming, based on renal ultrasound and everything, you know, the obstruction has been ruled out. She's not dry, you know, the usual typical stuff that we as nephrologists go through to exclude AKI. So I think this is related, and I think this is going to be a Cas nephropathy.
Great.
When you talked a little bit just a second about the amyloidoma, yeah, this was sort of news to me too, but these amyloidoma is really just a collection of the proteinaceous material and doesn't often have cells in it. It can be acellular, and it can have no clinical consequence unless it's causing discomfort. So it could be in the GI tract, and they just leave it and watch it. And it can be in the bladder, it can be in a bone. And if it's not causing discomfort, they can just leave it and watch it and don't even have any specific therapy for it. So it's just a collection of, you know, Congo red positive proteinaceous material that doesn't necessarily mean systemic amyloidosis.
Is it usually, Bill, associated with a paraprotein though?
Correct. It is not. It is usually not.
Okay.
Right. And in this case, there is no monoclonal protein on the, you know, on the immunofixation, and the kappa ratio is elevated, but.
There's no exactly, but there's some small evidence. There's
there's an increase
kappa restriction in the bone marrow and
right,
and kappa restriction of the plasma cells. But, you know, again, that by itself doesn't make a diagnosis. There's, you know, a lot of people have smoldering myeloma, or, you know, small levels of this. So that doesn't make a diagnosis either. It's interesting. Just to make a distinguish, this is not a plasmacytoma where you have a collection of plasma cells outside of the bone marrow, you know, like multiple myeloma equivalent, but it's not in the bone marrow. But this is an amyloidoma, not a plasmacytoma. So,
correct.
Yeah, I don't know that I've ever seen one either. It's kind of interesting. Dr. Corbett, you've written on paraproteinemia and amyloid. What do you think's going on?
So
What
Yeah,
would
I mean,
what would be biopsy conference without you talking and not unmuting yourself? So
Jesus God, give me a break. I mean, is there no justice in this world to give an old man a break once in a while? Uh, so, the whole issue with this amyloidoma, it is interesting. I mean, in dialysis associated amyloid, that's kind of what you see, right? You see these massive collections of amyloid. I don't know if they call them amyloidomas, but you see them in long bones and you can see it in the rib, but it's beta 2 microglobulin. I don't know that I've ever seen it. I don't know how often it happens with light chains. And Bill was kind of alluding to that. I don't know. I mean, I think Casey's done a nice job of pretty much covering all the bases. I think that the thing that I find hard to believe is that it's impossible for me to believe this is cast nephropathy unless it's just some really unique form of cast nephropathy without having light chain proteinuria. I mean, if he had no light chain proteinuria, that means all the tubules are essentially occluded by cast, and that would give you a creatinine of 9 by now, as opposed to 1.89. So I think that has to, all of these things, as Casey's already said, the light chain disease, amyloid affecting the glomerulus, cast nephropathy, you'd expect some level of light chain proteinuria or even albuminuria. I agree. I mean, I think, could this be some sort of funny vasculopathy that's led to chronic disease, which could give you interstitial fibrosis and little to no proteinuria at all? I guess that's a possibility and something we'll wait and see what we find on the biopsy. Could it be some sort of chronic interstitial nephropathy, totally unrelated to any paraprotein? That's possible. I don't know what it would be from based on the history and the meds she's on, but I guess it's something to think about. And yeah, probably as bizarre as anything would be interstitial amyloid, for reasons that I can't give you a good, I can't give you a good reason as to why she would have that. I mean, we talk about it, with Bill's always talking about with ALEC2. She's not Hispanic. I'm told, I think there was a chat that she was, that she's Caucasian. And I don't know how often that kind of thing would occur, and it would be kind of unusual. I don't know how often patients with ALEC will have a, elevated kappa lambda ratio, but the kappa lambda ratio being elevated is, a nice soft clue that this person is at risk of a paraproteinemia. I mean, you can't ignore that. It's pretty high. And I think, as we've talked about before, the so-called secretory myelomas or non-secretory myelomas have been eliminated by the advent of this nephrolometric assay, which will measure light chains to as low as 5 milligrams per liter, I believe. So it's hard to throw that out. But as Casey has kind of alluded to, it's hard for me to also bring that in as a cause unless she's got just some really unusual presentation. I mean, even with her having interstitial disease, I'm surprised, and this is just me, it'd be interesting to know whether she had an increased fractional excretion of beta 2 microglobulin. I know kind of a poor man's way of looking at this is total protein in the urine versus albumin. And I have to admit, I don't remember what the numbers were, but there was nothing really that significant. I mean, if her total protein creatinine ratio was normal, then it would be a really subtle finding. So I don't really have, even though I know I've talked more than I probably have been allotted time, have much more to add to Casey's nice differential other than I think this is going to be some interstitial process. And for lack of a better way of categorizing it, just chronic interstitial nephritis. And, I don't know what it's from. I mean, I think it's interesting to see plasma, kind of like an infiltrative disorder, like in lymphomas. There was plasma cells in there, big sheets. But I agree with, everything he said, and I agree with Roger. This is why you do a biopsy. I mean, 99% of the time we back into these diagnoses of paraprotein related kidney diseases.
So the problem is this patient, I think, had AKI. This patient was biopsied for within a month, creatinine basically doubled, right, Bill? And so, it's hard to put any of this stuff together. I mean, trying to put cast nephropathy with that is kind of, maybe that's probably why that diagnosis was so high. I mean, the audience is often right, in the polls. They're pretty smart. But, interstitial amyloid with nothing in the urine, enough, I mean, interstitial amyloid enough to double your creatinine and have no albumin or no proteinuria. I mean, we use albumin creatinine ratios and protein creatinine ratios to kind of get a sense of how much proteinuria and how much is, glomerular, and you'd think there'd be something there. And that's, why ATN was thrown in the poll, because, as I look at this, there's nothing really fits very well, which is kind of what everybody says. And I think, Casey, you had put cast nephropathy as your number one. Steve, I'm sorry, what was your number one?
Chronic interstitial nephritis, reasons that I don't have a good answer for.
Yeah.
Just by way of the fact that everything is so bland.
Mm-hmm. Dr. Reen had said something in the chat, and I want to see if you could take your microphone off, or if you had anything, you said something about the cyclin D1 importance. Do you know what that means, or is that a question mark? Where are we? Dr. Rubin, I want to know what your thoughts are on this. Mario, you on today?
I'm on and I have nothing to add. I mean,
I don't believe that. You're one of the smartest people I know.
well, no
Well,
problem.
here, one of the things that we always do is, if we have nothing to add, we just should reiterate what everyone else says. But maybe you're more honest. So, all right. Well, and then I think with that, maybe we'll spin the wheel. Does that sound like the right time?
Yeah, let's find out what she has. Let's spin the wheel.
Okay. All right. Wild card. Casey, why don't you read it?
Okay.
Go ahead and click on the screen, Gracie. Yep, there you go.
All right. Okay, so this is a high power trichrome. We have a nice score. We have some cortex on top here, and then we have medulla, nice artery here. I see, very little blue staining material in the cortical area. I would say probably less than 10% or so. That's blue, so not much chronic disease. I'll comment on the glomeruli at a higher power. This one large artery does have a lot of obviously collagen around it. So, but there's some material on the inside, so that may or may not be normal. But overall, I feel like there is very little fibrosis.
Yeah, I agree. And that's an arcuate sized artery. So it's a nice look at the anatomy of the kidney. The arcuate there separates the cortex, the top from the medulla, and then the interlobular arteries branch off of the arcuate sized ones there.
Okay. So here's a PAS stain. One glomerulus looks pretty good. There is not much mesangial expansion. There is no hypercellularity. The loops are open. The GBM looks pretty thin and delicate. There is no interstitial infiltrate. The proximal tubules here have a nice brush border. I don't see any tubulitis. The distal tubules here look pretty good. So at least here, I don't see any evidence of ATN, maybe just a little bit here in this one tubule up here, but that's kind of really stretching it. So this looks normal to me.
Yeah, that's also an arterial right there at 3 o'clock. That looks widely, no hyalinosis.
It's wide open, yeah.
Yeah.
So far, cast nephropathy is not looking good. Interstitial nephritis is not looking good. So moving on. Here's an H&E, high power, the glomerulus. I see a little bit more. This one has a little bit more mesangial expansion, and still the cellularity looks, for the age, is probably normal. I don't see really too much to write home about, and the capillary loops are still pretty open. So maybe overreading it, but pretty much a normal glom.
Yeah.
And the tubules, there's a little bit of, seems like early maybe evidence of tubular injury here.
Yeah, maybe the tubule up, yeah, above that one a little bit. There's some
Yeah, this
sloughing.
one here,
Yeah.
there's some sloughing going on. The interstitium again looks pretty clean. I don't see any plasma cells, lymphocytes, or neutrophils, anything that's infiltrating. So next is Jones stain. So we're looking at high power of a glomerulus. The staining of the GBM looks pretty thin and delicate. I don't see any holes. I don't see any spikes. This is the mesangial area. I don't see any splits. Not much going on. There are some protein resorption droplets inside of these tubular epithelial cytoplasms kind of throughout these tubules. So there is some protein being resorbed. Not sure if this is normal resorption versus pathological, but yeah, not a whole lot going on
Yep.
here.
Yeah. So now we're down in the medulla. So we look at
Okay.
the cortex.
Okay, so this is medullary tubules. These are a lot of distal tubules. They're very like spaced apart. This is clearly not normal. And there is this pinkish material that's expanding the interstitium.
Yep.
It's very like these tubules should be, I mean, if
Yeah.
looking at that, I'm just going to go back to the initial high power. Let's see. Looking here, like these tubules are pretty close to each other, but you know, when you get to that high power, they look pretty spread apart. So something is infiltrating the medulla.
Yep.
And this is same area. Yeah, you see some areas that are, this is PAS.
Yeah.
Some are, mostly it's PAS negative or weakly staining.
Right. Yeah. Yeah. The normal intensities of the
Yeah.
tubular basement membrane.
Right. So weakly PAS positive interstitium, have to see what that material is.
As I look at this, you know, I mean, you're obviously leading us to something with this, with your PAS weak language and that. But how do we
Amyloid?
know? Yeah. Well, now how do we know this just isn't interstitial fibrosis, David?
Well, because
Can you tell me with this alone that it really looks infiltrative to you, or it could just be tubular atrophy with fibrosis in a segmental area?
No, I agree with Casey's description. Yeah, the tubules should be more tightly packed. It looked like even when I had the H&E, it looks like there's some material here pressing them apart. That's amorphous. Yeah, usually the interstitium of the medulla has, you know, more vessels and you know, capillaries and cells, and this looked probably suspicious for some deposition.
I understand, but how can you convince me this isn't just a segmental scar, an area you picked up in the medulla that's just scarred?
Well, I mean, I have to do my due diligence and do a Congo red. I mean, if that doesn't pan out,
I understand.
Yeah.
No, I understand, but even just up to this point, you know, Casey's reading this as an infiltrative process, and I see usually when I see a picture with tubules that are separated by a lot of non-tubules, I think it's just CKD. So, is there something about this that tells you it's not fibrosis?
Because the cortex looks normal and this is all of a sudden spread apart. So why would there be if it's CKD and it's just fibrosis, it should be everywhere.
What if it's just a segmental scar in the medulla, you know, an old pile or something?
Or maybe that would be more blue on the trichrome. Since there wasn't much blue on the trichrome, we know it's not a scar. Would that be right, David?
Right. Yeah.
I'm not arguing at all. I'm impressed at the, you know, at the read. I'm just, you know, trying to look at it from the standpoint of teaching and how obvious it is to be able to make that call if that's where we're going.
Well, since we're on this, I mean, David, when you report out chronic interstitial fibrosis and tubular atrophy, you always usually specify in the cortex.
Yeah, right. The medulla doesn't typically scar over.
Got it. Thank you. Excellent point.
Okay. And so this is the Congo red.
Yes.
And I don't know. I personally don't see anything that's positive. I don't want to call it positive if I don't see it. So I'm not going to say this is negative. I mean, I see what the interstitial, what is meant to be stained, but I don't see it unless, I guess I have to go to the next one to see if there's any birefringence.
Yeah. It's
Oh, there
weakly
you go.
positive. Okay.
Yeah. Now I see.
Yeah.
This is positive in the interstitial.
Yeah, actually go to the next slide and then go back and forth. You could brings out the
Okay.
birefringence.
Yeah, perfect. Apple green birefringence.
Yeah.
And you see that some areas are going from the top right to the bottom left, and then some areas are going the opposite direction. Okay.
Yeah.
All right, so it's positive for Congo red. Here's immunofluorescent. This looks like it's, I don't see any glom, so this is in between the tubules. So this is interstitium.
Yeah.
And this kappa light chain is staining the interstitium.
And then before, knowing this was all tubular interstitial, Casey,
Yeah.
or actually, I'm not sure if we saw any vascular Congo red as well, but it was tubular interstitial. Do you think the lambda is going to be positive and there won't be restriction and we're going to find ALEC 2, or do you think it's going to be related to her kappa and the amyloidoma and all that?
Just because kappa is such a higher level than lambda in her case, I think we're going to still see lambda, but it's going to be maybe weakly positive, but which would make it non-restricted. So I'm going to go with weakly positive lambda.
So you're going to go, basically you're saying that this is not a monoclonal
Not a monoclonal related
renal disease.
Yeah.
So you're thinking maybe ALEC 2 or
some
secondary
other
something.
secondary amyloid or familial amyloid.
All right, let's see the lambda.
Is that kind of positive?
Yeah, that's, yeah.
Yes.
Sorry, Casey.
It's
We
a
love you, but
sense-
not this time.
All right.
Yeah, it's trace, and they're negative. Yeah,
So
yeah. So
there-
it's light chain restricted.
It is restricted. Okay.
Yeah.
All right.
Yeah.
So I stand corrected.
And then I went back and looked at on that fluorescence at the glomeruli. It seems there is some pretty minimal glomerular involvement of the amyloid. You could see a little bit at the hilum up at 11 o'clock, and then rare mesangial areas. And it looks like there's an arteriole over there on the left that's positive.
Here.
Yeah, but wasn't obvious, as we reviewed the biopsy.
Okay. Okay. It's interesting how this tuft is pretty much spared, except right here when there's almost like, I don't know if this is a vascular pole or.
Yeah, I think it is, because if you trace it
You see
down,
something
looks
coming
like-
out, right?
Yeah, and
So
within the glomerulus.
is this in the vessel?
Yeah, that probably is in the afferent or efferent
Yeah,
arteriole.
because it looks like it kind of splits.
Yeah.
Okay. Okay. Thank God we moved on from IF. That was confusing. Here's an EM, high power. This is a GBM. All these red blood cells are inside of the capillary. So this is the blood space. This is a urinary space. We're looking at the podocyte foot processes. They are, I'll have to look at it at a higher power. They look okay. There's some focal effacement, but I'll take a look at a higher power. Here's the mesangium. I don't see any obvious electron dense deposits here. Looking at the mesangium here, I don't also see any electron dense deposits. Somebody asked, is the GBM thin? It does look thin, diffuse, but it's not diffuse because there are some areas where the GBM looks, so up here at about maybe 10 or 11 o'clock, the GBM does look normal. And here, this particular loop, it looks pretty thin.
It almost looks like there's rouleau inside the glomerular capillary loop. The problem with that is that to have rouleau, you've got to have a significant paraproteinemia, and it really isn't present in the blood. So, but it would have been a nice little finding.
Yeah. Okay. All right, and here you can see the actual fibrils that I'm trying to think. So this is the GBM. Kind of loops around here.
Yeah, I think the
See?
fenestrated, yeah, I think that's the podocyte. what
This
you're
is the
on there.
podocyte on this
Yeah.
side, even though it's kind of looped the other way. So
Yeah.
yeah, the fenestration here, you can see the fenestration of the endothelium. So there's blood side on the right, urinary side on the left. Here's a podocyte. And so here's the GBM, which has this large area of amyloid or
An amyloidoma.
amyloidoma in the kid on the
Yeah.
GBM.
Yeah, you can make out the fibrils
Yeah.
at this power.
David, were you able to measure them?
No, the Mayo Clinic, these are images from the Mayo Clinic. They didn't give a measurement.
Oh, sorry.
Okay.
Back.
Oh, boy.
10 to 15 nanometers, I'll bet.
We'll have to talk to them.
Yeah. And then, and back, yeah, you can see the randomly arranged non-branching fibrils.
So David, you showed the one in the glomerulus, but what about all that interstitium? Or you don't have an
Yes.
EM of you don't have an EM of interstitium, do you?
It's similar to what you're seeing right on the slide in front of you.
I mean, it's interesting because the interstitium was full of it, and you had to kind of look pretty extensively to find any
Yeah.
glomerular
Yeah.
Congo red. And we all know that Congo red in the glomerulus doesn't always correlate with proteinuria, but that becomes a moot point here because there was no proteinuria.
I was just gonna say, it's usually the opposite of that, right, Raj? I mean,
Exactly, yeah,
massive
that's what I'm-
proteinuria with little Congo red.
Yeah, that's what I was trying to get at.
Yeah.
Thanks, Steve. Yeah, exactly. So
The other thing too is with the EM, I mean, what David was showing was everything that was in the medulla for the most part, right?
Yeah.
mhm.
And so the real question is how much of the EM actually had medulla on it?
Yeah, I don't know if that.
Yeah. They photographed several medulla. Right. Yeah, of the medulla. Sorry, I was thinking mesangium. Yeah, I'd have to go back and look at the pictures. I mean, they did photograph some interstitial amyloid fibrils.
No, but I mean, I agree with Roger. I mean, the medulla was where the money was on this one. and
Yeah.
You would think the medulla would be filled with this stuff.
Yeah. So Casey, what's your diagnosis?
So this is interstitial amyloid on the histology, and then there's kappa restriction. So you have to kind of chase a paraprotein related amyloid.
Yeah, and I think this is a good proof that we don't, we don't know these cases when we go into them. Sometimes we get it right, sometimes we don't get it right, and it's not even has anything to do with it's the discussion that gets us there. But I think to think this would be interstitial amyloid based on the reason the clinical presentation would be highly unusual, and I think that's why people voted the way they did, and I think they voted what they would think the most likely based on the AKI. And I'm still a little confused how this does AKI. In a month, medulla, the gloms look pretty good, and the rest of the tubules look pretty good, and I didn't see any ATN. That within a month you could have doubling of your creatinine from some medullary amyloid, but given that's the way it was, and probably fortunate for her because it led to Dr. Whittier doing the biopsy and making this diagnosis.
Yeah, it was really done for unexplained AKI. Dr. Painter's the oncologist, and she was referred to the patient because of an amyloidoma, and then she basically said that this itself wouldn't need treated, and she said she's wondering if it's in the kidney. And I looked at the case and evaluated, and I was like, boy, I don't think so. I think there's got to be something else here. Either she's taking a medication that's causing interstitial nephritis that she's not telling us about, or there's some other type of kidney injury. Without any proteinuria, I was very, very surprised to see the diagnosis that we had here.
Yeah,
so
in fact,
typically,
in fact, I'm sorry. Let me just say one more thing. Excuse me, Dr. Painter. Dr. Salzberg, I think he's on, he would always tell the story of the one case that he was told by Bud Rose of the patient with vascular amyloid that presented completely, with completely normal urine and no glomerular, no interstitial disease. That I don't remember if it was AKI or CKD or whatever. So it can go in a lot of places, but to have this much interstitial and not have some urinary findings are unusual. Bill, I'm going to give it back to you and Dr. Painter, and you guys can take it from here.
Yeah. So before we get to treatment, maybe and before I ask Dr. Painter to weigh in a little bit, can I go through my slides, Prabir? I just have a couple, and I just wanted to really reiterate the point of how you can go to the next slide, how unusual it is, one, to have just tube interstitial amyloid in the setting of AL. We really see it in ALEC2 and some of the other ones. But I thought it'd be good a time to review the types of amyloid and the frequency of all the different types. AL, of course, is the most common, and this is from mass spec of thousands and thousands of cases. And this isn't all from kidney biopsy specimens. This is all from even heart biopsies, or all the different tissue that has been found to have amyloid in it. And you'll see that AL is the most common, and ALEC2 is even more common than actually secondary AA, which is not really the as much as we see it. Next slide. And this is another study that did mass spec on all the different tissue that they got. So just thousands and thousands of amyloid specimens, and you can see that depending on your organ involvement, your type of amyloidosis also has a decreased frequency. And so in the kidney there, it has the majority are AL, but then almost 20% are ALEC2. And then we get our secondaries are around 15%, as opposed to other organs. And if you can look at the next slide again, we always talk about AL and then secondary, then ALEC2, and we often talk about transthyretin. But if you look how common transthyretin was in the heart, that's the most common amyloid there, even more common than AL. And look at all these almost 2,000 kidney specimens, and they didn't have one single case of transthyretin in the kidney. So it doesn't mean it doesn't exist, because there are cases of proteinuria and biopsy proven transthyretin in the kidney, but it's much more common to be affected in the heart.
I want to point out to the fellows that you need to know every one of these percentages for the boards, otherwise you'll have no chance. So
yeah,
take
that's
a screenshot and memorize these exactly. They'll be, I guarantee they'll be on the boards.
That's why I put them in the slide, because there's no way I can memorize it. Yeah, you can go to the next one. And really the renal part about this case was that it was really just not predicted. I mean, when we think of AL amyloid, it comes in with glomerular involvement, proteinuria, albuminuria, nephrotic syndrome. We even think about that with secondary amyloid. Most often it's somebody with some chronic inflammatory state, and they have sudden onset of nephrotic syndrome and enormous amount of albuminuria. So when we see interstitial amyloid, we're usually linking it to ALEC2 or one of the other rare ones. But in this case, we did have the kappa light chain restriction. And that being said, kappa's less common too with amyloid compared to lambda. So this was really an unusual case in several different features. So I asked Dr. Painter to come on to have some comments too, and she can also take us through the treatment that we wanted to do. I would say that this woman, without giving details away about her social situation, has an unusual social situation that she's not able to pay for a lot of therapies. So I think we're getting a little bit creative in when we're talking about what therapies. But maybe we could go through what your therapy would be in a standard patient and talk about some interesting features that you thought of, Dr. Painter.
Yeah, thank you for inviting me. And it was really interesting to see pathology and hear your perspective. When I met this lady for the first time, my concern was that she may have CAS nephropathy because she was coming in with AKI, but her light chains were relatively low. So in the next thing would have been amyloid, but again, because she had no proteinuria, it didn't fit the classic picture. So I'm really grateful that you did kidney biopsy, because if she had only rib involvement with amyloidoma, and on her bone marrow biopsy, she has MGUS level of plasmacytosis, not quite enough for us to call it multiple myeloma, I would observe her. I would not treat her. You could have localized amyloid that doesn't cause any trouble over the years. And I would just watch her as someone who's at risk to develop systemic disease or turn into multiple myeloma over the time. But she does have vital organ involvement, and that is an indication for treatment of amyloidosis. And we are here quite on the verge of changes in how we treat amyloid. In general, I would say in somebody who has only one organ involvement, and is a candidate for autologous stem cell transplant, not kidney, but bone marrow transplant, that would be a preferred treatment option. She also had translocation 1114, which is by far the most common in amyloidosis. 40% of patients have it, and they seem to be particularly sensitive to melphalan. So this type of patient with translocation 1114, kidney-only involvement, low kappa light chain level, they are most likely to have good long-term survival. This is where we see progression-free survivals over a decade. Now, last year or year before, with COVID, I'm a little bit confused with times, but basically it was, actually it was 2020, yes, in ASH, there was Andromeda study presented of daratumumab plus CyBorD. So CyBorD stands for bortezomib, Cytoxan, dexamethasone, and that has been standard of care, even though it didn't have FDA approval for that indication. It has been standard of care treatment for multiple for amyloidosis for patients who are not candidates for transplant. And Andromeda study combined it with monoclonal antibody and TCD38 antibody daratumumab, and showed that you can indeed increase considerably hematologic response, which is usually a prerequisite for organ response. And the way they measured organ response was a very interesting composite endpoint that included deterioration of kidney function, like going for dialysis, transplant, death, and similar markers of the heart deterioration. So they showed by adding daratumumab, again, you considerably improved organ response, which is really what matters to the patients. So that study puts a big question whether patients should still be considered for transplant, whether we should only be sending to transplant those who don't respond to DARA, CyBorD. But by doing that, you're also risking that patient who is a transplant candidate can no longer be a transplant candidate after you run a trial of DARA, CyBorD, if they encounter toxicities or their disease progresses. So it is a somewhat controversial area, what would be the ideal treatment in 2022. And I would say long-term data stands with transplant. This DARA, CyBorD was just approved in January of 2021, shortly after it was presented in Hematology Society meeting. So we really don't know yet long-term what is the patient's progression-free survival and organ response.
Yeah, I think there's all these challenges in real life, and I'm glad you brought them to light here. So thank you for that. I think ideally, though, in the ideal patient, you'd probably have them go for transplant right now in 2022, is what you're saying?
For this type of patients, I would still go.
Yeah.
Yeah.
And then
the
role of the I think that there was some comment earlier before you were on about cyclin. What was it? She was cyclin 1 positive.
Cyclin D1.
Is that a prognostic factor, and does that influence your treatment decision?
No, it just usually goes with translocation 1114.
Oh, sure.
So
Okay.
it's a immunohistochemical stain that usually correlates that patients have that genetic abnormality.
I see. Okay. Okay, well, great. Well, thank you. Thanks for helping to explain that with her treatment, and thanks for coming on to our conference. I really appreciate you being here.
Thank you so much.
I want to make a point. We're lucky that we have Dr. Painter. I'm involved a lot with ASN communities, and cases come up all the time with paraproteinemias and where it's not found here, it's only found a little bit here, but they're not comfortable treating because it's not classic multiple myeloma kind of case. And we're fortunate to have somebody that's really attuned to all the multiple phases of paraproteinemia and renal disease, and is aggressive with us to make a diagnosis with a biopsy, because the truth is, as she said, as Dr. Painter said, 5% plasma cells isn't enough to do anything about, and maybe even with an amyloidoma isn't enough to do anything about. But now we're talking about a whole nother level of bad when you've got the AKI and this renal interstitial involvement. So I think it's a really interesting case. And, I've had these situations in communities where people have had to seek a second opinion because their hematologists were still too tunnel visioned about this. They're not seeing a bony lesion, they're not seeing the criteria for myeloma. And there's a lot more to these paraproteinemias than just the classic myeloma definition. And so you have to have an open mind. So we're lucky to have you on faculty at Rush and to work with us like that.
Thank you so much. Thank you for your kind words. I love collaborating with all of you. I'll have to take off here for another conference for our HEMONC fellow. So thank you again for inviting me.
Thanks for being here. Mario, you had something you want to say?
Yeah, I got the impression from David that the tissue was sent to Mayo. Did they do a mass spec and a final diagnosis on this?
No, just for the EM, as our EM scope was having technical problems, we weren't able to get photos of the fibrils, so that they processed the EM tissue there. There was no reason to do mass spectroscopy in this case because the fluorescence made it obvious that it's light chain amyloid.
Your final diagnosis is an AL tubulointerstitial form of amyloidosis.
Well, no, because there was also some predominantly interstitial, but there was some focal glomerular involvement also. But yes,
the
AL
answer is yes.
amyloid.
Yeah.
Good.
Bill, has there been any recovery of her renal function? Any idea why her creatinine doubled with that?
It has stabilized, but not recovered. So the next time that she came in, she actually had hypercalcemia too. Her calcium got up to 11 now, so the creatinine went up, but then IV fluids made the calcium better and stabilized her. So she's still hanging out around a creatinine of 2. Again, she hasn't really undergone this ideal therapy because we're dealing with some social issues.
So, if she had hypercalcemia, did you get a skeletal survey then, or?
Yeah, and it was normal.
Okay.
And actually, she even had a PET scan. She's had several other things that I wasn't able to really include for the conference, but her PET scan only lit up where the rib was. And in case it didn't even light up in the kidneys, and I didn't know if it would or not, but it didn't.
There's so many lessons in this case, which I'm not going to repeat all of them, but one of them that I want to really make a strong point about is the sensitivity and specificity of serum free light chains. And this was not a ratio that was, slightly elevated because of, for instance, renal failure. This is a very high ratio, a very high kappa level, yet no paraprotein was found in the serum or urine immunofixation. And Steve brought up these, non-secretory myelomas may not exist anymore because we just didn't have a way of picking them up. And this would have probably been considered a non-secretory something, myeloma or something. And so it's really remarkable how important this test is and how much it's changed our workup and finding patients. Although, the SIP and UIP were normal, but here we had a very, very interesting, and to have a light chain ratio and to have this so low in the blood, you're not even picking, where you're only picking it up by the light chains, and yet it's still depositing in this rib and very significantly in the kidney. It just, it just tells you that, I've always thought it's because the kidney sees so much blood that it's more prone to it, but that's, usually my explanations are oversimplifications.
No, but I think you're spot on though. I mean, the whole issue was that, if you go back and look at the old serum protein electrophoresis, which we used to use looking for the gamma spike or the M spike, the sensitivity there was, I want to say something like 500 milligrams per liter. And then with the serum and urine immunofixation, where they look at the abnormal Boeing and they can tell you what protein, it's still like 50 milligrams per liter. Now we're down to like 5 milligrams per liter. So it's like, it just goes to show you that this is so sensitive. It picks it up at such a lower level than what we've had before. This whole category of non-secretory myeloma has essentially been eliminated. But it just, as I think you're alluding to, who knows how long this has been going on in this lady. And these deposits have just been slowly occurring over time, and the kidney's been compensating. And then all of a sudden at some threshold, there's enough deposit that you start to lose function. It's not meant to be diagnostic, you don't use this as a screening tool per se, is what I've been told in the past. But when you've got a situation where you've got renal insufficiency or this plasmacytoma, you've got a reason to do it. I think it's a key tool. And Agnes didn't talk about it, or we didn't ask her, but this is one of the tools they use to look at determining response, right? If there's a 50% reduction in free light chain, that's actually considered a response. So because you can quantitate it, unlike you could with immunofixation. So this nephelometric assay has really kind of been a game changer.
Yeah, there's a question in the chat that says, what would you do with renal AL amyloid, normal free light chains, normal SPEP, UPET, et cetera, normal bone marrow biopsy? And to me, that's, very similar to the, the monoclonal gammopathy of renal significance, where especially these proliferative with immunoglobulin deposits, proliferative glomerulonephritis with monoclonal immunodeposits.
Pigment.
Yeah, you
Say that
pigment.
again.
Yeah, pigment. That they often find no clone, and it doesn't matter if you can't find the clone. If you find end organ damage that's light chain restricted, that deserves treatment, and that really gets to my point, which I said about Dr. Painter recognizing that if you don't find it in the bone marrow, but if you find light chain restriction and end organ damage, that's enough. And we've seen it ignored before pre-transplant, and then it comes back in a transplant because it wasn't taken seriously. So I think it's really important for people to realize that something, that will trump everything else. And like I said, fortunately, we've got a really excellent hemo-oncologist, hematologist that understands this and works really closely with us. Bill, do you have any further comments?
Coronary CT scan to the rescue, I guess, for everybody, because this is the way this whole thing was all picked up. Just very, very unusual, and keep remembering to think outside the box. Yeah, absolutely. Great case. Thanks, Bill. Thanks for everybody discussing. And I'll wrap this up. Our CME activity code for this week is 485638. We'll be back next week with another great case. And until then, everybody stay safe. Thank you.